Thank you for coming, especially at such a busy time of term. We're almost there. We're so close. But we're going to be finishing off this last week very, very strongly, actually, with all the people on this side, with Phoebe today and Pythagoras on Wednesday. I'm just thrilled about it. Don't forget as well, before I forget, and thanks to Carrie for doing all the heavy lifting here, about the holiday party, which is coming up not this week, but next week, next Wednesday, in lieu of the kind of the research series slot. So it'll be 12 to 2. Please come, enjoy. There is a white elephant gift exchange if you feel so inclined, but no pressure to participate in that. If you bring a gift, then you can participate though. So that's going to be a lot of fun. Today, though, we're thrilled to be able to host Phoebe here, Professor Jean-Pierre. She is an assistant professor, brand new to IU this fall, which we're very excited about. Coming from Iowa, her research lies at the intersection of health and health law and explores issues involving race and persisting disparities. She's interested in risk, crisis communications, doctor-patient confidentiality, health disparities, and immigrant health, privacy, protected health information, social media and health, and ethical and legal issues in health communication. Not much there, right? No, plenty to unpack, which is really exciting, which we'll start by doing with their excellent paper, Diagnostic Error in Racism and Implicit Bias, the Persistence of Health Disparities. So Phoebe, we're thrilled to have you here at the workshop and look forward to your talk. And per usual, I'll keep the cue right afterward. Let me actually get that open now.
I want to thank each and every person here today, both in person and on Zoom. I appreciate you taking the time to listen to me present and help me make this into an even better paper. Before I dive into the talk, I just want to go over what are my goals for this session and what I'm really seeking feedback on. The two main areas of my paper I intend to focus on today are sections 3 and 4. Section 3 covers diagnostic errors and our attempt to mitigate these errors. Section 4 focuses on the widespread harm caused by diagnostic errors within our healthcare system, but also within society. I am requesting feedback on my overall argument in these sections, and please let me know if you feel there's anything missing that may aid the clarity of my overall argument. And with that, I will get started. To start, I just want to set the scene. Why are we talking about medical error, and in particular, diagnostic errors? In 2000, the Institute of Medicine published the infamous report, "To Err is Human." It was this report that brought medical error to the attention of the public. Over 2 decades later, medical error rates remain high, and in particular, diagnostic errors pose a unique set of challenges. Although diagnostic errors were highlighted in this report, for the most part, they have been overlooked within the field of patient safety. When talking about medical error, it's also important to understand its relationship to patient safety. Often, reducing error is seen as a way to increase patient safety and create safer environments for patients. Broadly, patient safety can be thought of freedom from accidental injury. Patient safety and medical error have been studied for well over a century. Over time, our perspective on how we view medical error has shifted. In the 1950s, medical errors were primarily viewed as diseases of progress. Healthcare at that time dismissed these errors as merely the price we pay for modern diagnosis and therapy. The publication of "To Err is Human" helped to bring medical error into the public eye, but it also moved away from these early notions about error and instead advocated for change to make healthcare safer for patients. Now we will move on to medical error and the concept that to err is human. The Hippocratic Oath instructs medical providers to do no harm. This has been a long guiding principle within the practice of medicine and the delivery of healthcare around the world. Unfortunately, harm occurs every day in healthcare. Human errors represent a considerable portion of preventable mishaps in healthcare. Even the most competent clinicians are not immune to it. Aside from the harm that occurs, there is now a growing public awareness about medical errors and adverse patient outcomes. Medical error is a serious public health problem that needs to be addressed in a timely and efficient manner. With this brief introduction to patient safety and medical error, we're going to move on to the focus of my paper, diagnostic errors. Diagnostic errors are errors related to missed, delayed, or incorrect diagnosis, and they represent an important type of error in medicine. Diagnostic errors occur in many cases, and their consequences may be severe. In section 3 of my paper, I focus on diagnostic errors and our attempts to mitigate them. For today's presentation, I'm going to focus on breakdowns in clinical reasoning and briefly touch on breakdowns in our healthcare system. As I've discussed, medical error is a major concern within the space of health. It is incredibly important that we create safer systems for our patients and maintain a safe environment. Diagnostic errors are a type of medical error, but they are a bit unique. Diagnostic errors are both a part of the healthcare process and involve decision-making. These decisions during the diagnostic process cannot simply be automated. These decisions, successfully addressing diagnostic errors goes beyond making system-wide changes, but also responding to this cognitive component. Given the significance of cognitive decision-making in the diagnostic process, it's important to understand the potential for breakdowns in clinical reasoning. Diagnostic errors are common in medicine, and the occurrence of these errors can be traced back to cognitive biases and heuristics, mental shortcuts used by clinicians. Diagnostic errors are different from other medical errors due to the cognitive component in the decision-making process. Making a diagnosis is not something that can be automated. Choosing a diagnosis requires making cognitive decisions. Some experts suggest that up to 75% of diagnostic errors can be attributed to failure in clinician thinking on diagnostics. Extensive research exists on how faulty thinking processes can lead to error. Unfortunately, little information exists about how to prevent these errors. Traditionally, in resolving diagnostic error, overemphasis has been placed on the use of technology and automating systems, as opposed to focusing on the human and cognitive elements. A successful framework to address error should be more varied and incorporate these different elements. Just briefly, I will touch on breakdowns in the healthcare system. The decision-making and cognitive part of diagnostic errors is what makes them particularly difficult for us. Despite the concern with faulty thinking and the cognitive component of the diagnostic process, sometimes technology is the answer. There has been some research and a few examples that show making certain changes to the healthcare system can influence rates of diagnostic error. Though related, my goal moving forward is to build out this section on the breakdowns and healthcare system a bit more and focus on the relationship between the healthcare system and human decision-making, as both components are key to making a significant change in the rate of diagnostic error. The next part of my paper focuses on measurement and terminology used around diagnostic error. My goal here is to show how different measurement and different definitions can influence how we perceive and address diagnostic errors. Though diagnostic errors have emerged as a significant cause of harm to patients, they rarely rise to the level of other priorities in healthcare organizations' patient safety programs. Many factors contribute to why diagnostic errors are often not seen as a high priority. Diagnostic errors are difficult to define. Further, it's difficult to pinpoint exactly when the error occurred. Consequently, diagnostic errors tend to be overlooked or discovered late in the healthcare process. This raises the concern that we don't know how to measure these errors or we measure them inconsistently. This lack of effective measurement makes it difficult to capture the full scale of the problem. Another big problem is the lack of a consistent definition. If we don't have a central definition about what is a diagnostic error, how will we know when it's occurred? I believe both of these aspects, the question of measurability and the issue of definition, are important. One thing I wanted to pose to the, we can get back to this more during the discussion section, is do these points belong in this paper? I believe there's a good case for the issue of how we measure diagnostic errors, but on the point of how we define them, there is so much more that could be added to this particular point that it may be best suited in the future. I look forward to hearing your thoughts, but for now, I'll continue on my argument of how diagnostic error affects people in different parts of society. Diagnostic errors are incredibly widespread, yet have frequently been left out of the conversation about medical error. In breaking down the problem with diagnostic error, I look at three key areas. First, I look at diagnostic error and the dangers it poses to the US healthcare system. Second, I look at the relationship between diagnostic error and our current medical malpractice system. Medical error is known to be incredibly costly when looking at malpractice suits, and diagnostic errors are no different. Third, I consider diagnostic errors in vulnerable communities. Evidence suggests that while diagnostic errors affect everyone, they come to fall and burden vulnerable communities. The US healthcare system has a problem. Hundreds of thousands of people die each year, and over 1 million are injured by medical mistakes that could have been avoided. The prevalence and reoccurrence of errors prevents us from providing patients with a safe healthcare system. One major challenge with diagnostic errors is its widespread nature. Diagnostic errors present a challenge for virtually all medical specialties and a significant threat to healthcare quality and patient safety. Despite their widespread and frequent occurrence, these errors tend to be less understood than other types of errors. A resulting diagnostic error may span across different medical departments. In some cases, reaching a proper diagnosis, particularly for a more serious illness, requires the coordination of doctors, nurses, and technicians across primary care facilities and specialty practices. Despite the widespread and detrimental effects of diagnostic error, they receive little attention in comparison with other types of medical error. The lack of attention allows for the persistence of high rates of diagnostic error. Diagnostic errors remain obscure because healthcare organizations fail to see them as a high priority and fail to recognize them as a systemic problem. This reflects an institutional disconnect as to the dangers and pervasiveness of diagnostic errors. Harm to patients due to medical errors persists, despite the many reforms made to the medical malpractices. Unfortunately, when seeking to respond to harm in the aftermath of an error, there are many competing interests. Reforms often focus on reducing insurance costs and liability of providers, as opposed to responding to the harm suffered by patients and their families. Given the history of our medical malpractice system and the continued lack of focus on patient harm, there is frequently an overuse of filing malpractice suits. The use of malpractice to resolve harm has become a mainstay in our legal and healthcare system. Specifically, problems in care relating to diagnosis often serve as the basis of lawsuits. Data from malpractice claims indicate diagnostic errors are the most common, the most costly, and the most dangerous type of medical error. Further, research has found that 25 to 59% of malpractice claims were attributable to diagnostic errors. Not only are diagnostic errors a frequent cause for filing a lawsuit, but they are financially costly as well. Now I will move on to discussing the dangers that diagnostic errors pose toward vulnerable communities. I will start with racial and ethnic minorities. Medical error and diagnostic error are a problem for everyone, but these errors disproportionately harm some of our most vulnerable communities. Racial and ethnic minorities experience great disparities in the quality and safety of healthcare they receive. These discrepancies are due to various social cultural factors, efforts to improve patient safety have underestimated and failed to recognize the critical relationship that exists between culture, language, and the safety and quality of care for patients. Patient safety among racial and ethnic minorities remains a great concern, as this population is at a heightened risk to experience preventable adverse events. Despite worldwide efforts to improve patient safety and the quality of care, limited focus has centered on improving safety for ethnic minority populations, and this remains an under-researched area. Throughout history, treatment and diagnosis of women in medicine has hinged on the male perspective, and often the assumption that what works for men will work for women. Women continue to be overlooked in medicine. Historically, medical education and research have been male-focused, specifically on the white cisgendered male. Within medicine, there exists a foundation of research conducted on the white male, with the assumption that this data could simply be extrapolated into other racial and ethnic minorities. Research has found sex-based differences as an important variable that affects health and illness. How women respond to disease or react to a treatment will likely be different than men. Beyond the history of centering white men in medicine, misdiagnosis, a type of diagnostic error, can have gendered consequences. Misdiagnosis can happen to any patient, but research indicates the gender of the patient seems to influence when and whether a patient is diagnosed correctly. Studies have found gender disparities in rates of diagnosis. Women have a lower likelihood of receiving a proper and timely diagnosis of cancer and heart disease in comparison to men. This has been particularly pronounced around women experiencing health. Research has found that doctors misdiagnose heart attacks in women because they had been trained to look for more common heart attack symptoms in male victims and may not recognize serious heart attack symptoms among women. When a heart attack is not properly diagnosed, this can lead to serious health implications for the patient. And given the current rates of diagnosis, these health implications disproportionately affect women. In recent years, the social climate in the US has shifted, leading to a steady increase in legal rights and social acceptance and visibility for lesbian, gay, bisexual, and transgender, what I'll refer to as LGBTQ+ people. Despite this progress, there are still marked differences in levels of sexual prejudice. Discrimination faced by the LGBTQ+ population extends into healthcare. Generally, research about the health and even the size of the transgender population in the US has been limited. Information like gender identity or transgender status are rarely captured in public health or health services data collection, which makes it difficult to assess the demographics, health, and other characteristics of the transgender population. As a note, one goal I have for this section is to build out the relationship between diagnostic error and the LGBTQ+ population. As noted, research on this population is fairly limited, and with it, so is our knowledge and understanding of how diagnostic errors may influence this community. In looking toward the future and how to address and reduce diagnostic errors, I think there are 4 potential solutions. The conclusion is an area I intend to add more information and further develop my arguments. For now, I will briefly introduce the 4 solutions I suggest to help start to address high rates of diagnostic error. I'll start with high reliability organizations, or HROs. Medicine is not the only field where workers work under high stress conditions with the potential for great harm or catastrophe. HROs present a great model for how to handle high levels of risk. And some of these ideas could be incorporated into healthcare. HROs refer to organizations that operate in complex, high hazard domains for extended periods, often without serious accidents or catastrophic failures. Examples of HROs include aircraft carriers, electrical power grids, wildland firefighting, power plants. The concept of an HRO is attractive for healthcare due to the complexity of the healthcare field and the significant potential for great risk should an error occur. Now let's consider just culture. Just culture refers to a system of shared accountability. Within just culture, organizations are accountable for the systems they have created. They are also responsible for employee behavior and responding in a fair and just manner. Employees are also responsible for the quality of their choices and for reporting errors and system vulnerabilities. Creating a safe and transparent environment encourages the reporting of mistakes. This in turn can improve the care offered to patients. Another potential avenue to improve patient safety is to take a patient-centered approach. Moving away from an over-reliance on technology toward greater involvement with patients and their families can lead to a safer environment for patients. Some research has suggested engaging patients on multiple levels to help them become co-producers for safer medical diagnosis practices. Given this potential, more research is needed to examine how engaging patients and their families in the prevention of diagnostic errors can help reduce these errors. And finally, patient safety paradigms. Implementing key safety paradigms can help to reduce the frequency of diagnostic errors. Research has suggested 4 patient safety paradigms to shift how we consider and respond to diagnostic errors. First, consider the diagnosis as part of a system. Second, less reliance should be placed on human memory. Third, in our response to diagnostic error, there needs to be breathing space to be able to reflect and discuss what happened. And fourth, successful reduction of diagnostic error will require the use of multidisciplinary perspectives and collaboration. This is just a brief summary of how my paper argues we can improve rates of diagnostic error. Thank you again for your presence here today. I look forward to any questions or comments.
Well, probably the most polished presentation and well done that we've had the whole term. So extremely well received. So I think there's a lot for us to chew on there. My goodness, it's an issue that some of us have dealt with directly or indirectly, unfortunately, and it's also front of mind, I think, for policymakers. So I think this is ticking a lot of boxes for us. So I see, maybe I'll ask if there's any students first who might have, a comment or question before we turn to, and it's okay if not, but I'd just like to give you guys the first dibs. I know it's the end of term. Okay, so Jess, we'll start with you. And then it looks like we have a chat from Kevin there online. And then if there's others who'd like to use either the chat or the raise hand function, just let me know. And then I as well. Perfect. So yes, Jess, kick us off.
Well, thanks for this. And I should warn you that I am the only non-medical doctor in my family. I know that's enough to be dangerous and annoying.
There's still time, Jess. You can go back for that, MD. But Jess leads our environmental and natural resource grant as well.
So I have a couple of questions and a couple of comments.
Mhm.
My questions have to do with things like, what is the role of M&M review in how you are thinking about this? You think that is a good space or not such a great space for these kinds of questions? They have different characteristics at different institutions. And so doctors and particularly attendings and residents see them differently, right? And they may or may not provide different kinds of spaces for the kinds of reflection you're talking about.
M&M review.
Oh, I was thinking a mortality review. It's essentially a conference that happens after there's an adverse event in a patient where there's the need to come together and reflect. And in some cases, some doctors feel as though it is essentially an interrogation of what they did. And in other cases, it can be more helpful in the way that has been suggested. And so that then leads me to one question and then a comment. Question, which I guess may also be a comment, so I apologize, which is, It seems to me, and you point out very astutely, right, the difficulties in diagnosing diagnostic error, right? Or identifying diagnostic error. And it seems to me that so much of diagnostic error is in many ways contingent on the state of the medical and clinical field. In other words, here's an example, maybe a little bit more real world. My sister is a neurologist who is experiencing persistent deafness and tinnitus in her ear, had an invasive brain procedure to see if there was an additional connection in her neurology that they could sever and would fix the problem. That was not the case. There has been no diagnosis. One could argue that this is a lacking diagnosis, but the state of the field is such that they can't possibly know. Right? So whether this is COVID, whether this is COVID vaccine, which is totally unrelated to either of those things. And so to my mind, right, it's not just, oh, this is a challenge that we have, but ontologically, identifying diagnostic error is very contingent on the state of the field in clinical practice. And so I'd be really curious about if or how you think there's space for that conversation, because I really do think, to your first question, that diagnosing and understanding diagnostic error and like what the challenges are is really, really an awesome thing to talk about in this paper. So I really think that you should do that, because I think people get that question. And then finally, a comment / suggestion, which is there is a fair amount of literature in biases and cognition and medical decision making, some of which is in your paper, but like even Kahneman and Tversky, right? Like Kahneman at some point decides, I'm going to take my, Nobel Prize winning perceptions on cognitive biases, right, and probability theory, and think about them in this exact context, right? And then lots of people have built on that. And I sort of be curious to sort of see how that interacts with the sort of ethical and legal context that you are thinking about. Because I think there could be some really interesting conversations to have with that literature. All right, I'm gonna stop talking.
No,
And again, I'm sorry for.
No, thank you. I appreciate, your questions and these comments that you've put forward. So to start with your first question about M&M review, that is not something that I've heavily discussed in this paper, but I do have a previous paper that looks just at medical errors in general and vulnerable communities. And so when thinking about aspects like, M&M and bringing people in to have these reviews about what happened or what went wrong, there's a lot that needs to go into how do we build these systems and how do we make this effective? How do we move it away from, oh, we're blaming you, or oh, we're shaming you, into a space where it's more of, this terrible thing happened. We need to talk about it because we don't want it to happen again. And how can we create a system, right, that prevents this from happening again, but also a culture that allows people to come and speak more freely. And on that end, there's a lot that has to go into it. You can't simply have these reviews and be like, oh, we've resolved it. So I don't get into it too much in this paper, but there's a lot of history in medicine where when error occurs, the natural response is deny and defend. Right? We're going to deny anything happened and we're going to defend our stance, and we're just going to continue on that track. And that's been dangerous for a lot of reasons, because these errors have been missed and overlooked and not addressed, but also the harm that patients and their families suffer also hasn't been addressed, right? So you're combating this history, but you also need the institution itself to have buy-in, right? So if the higher ups and if people at the hospital don't really believe in this type of review or in these types of conversations, or it's more of, okay, well, we have to do this, so let's check the box, you're not going to see the type of effective results that I'm advocating for, right? You're not going to see this concept of just culture that I touched on a little bit at the end. So I think this point could be helpful to bring into this paper to say, there are some mechanisms in place where we're trying to get at what do we do, when something terrible happens, but also recognizing the way that some of those sort of mechanisms in place right now fall short, and thinking about how can we make these better. To your point about, whether there's a diagnostic error and how we identify it is contingent on, the field of medicine, I think is a fascinating point, and one that I myself am still grappling with. There's so much that goes into whether whether we know a diagnostic error has occurred or not. And I think having that, I think that conversation is valuable. And I think you sort of touched on that, but there's so much, I feel like that could be its own paper. That on my end, I need to do more digging in how just the way we've set up this healthcare system, how does that prevent us from recognizing when we make these mistakes? Or what can we do differently to try to catch them? How are we categorizing this? How are we capturing that? But there's so much there that I myself am just starting to dig into. So I'm happy that you brought that up. And then your point about biases and cognitive decision-making, that's something that I really struggled with for this paper, because a whole rabbit hole on like human psychology and how we make decisions, and I have to pull it back. But I think that's definitely something I'm interested in for the future as its own separate paper. It's just fascinating how we make decisions, the biases that exist there, the way we've created society and how that either, creates these biases or feeds into them. So I appreciate that point, and I will try to maybe add a little bit more in this paper or polish it up, but I'm trying to keep myself from taking that deep dive because there was a lot of rich and good information.
I can just two-finger on that. I think that you'll be able to make much more concrete recommendations at that, because it seems to be your goal is to make clear statements about what could be done better. But I think those could be more specific and convincing if you can draw really specific. Okay, we know these biases come here. For instance, like we value risk, like we essentially, there's a reason why we're like risk aversion is squared. And it's because our cognitive biases are that we are much more angry if we lose something than we are happy if we gain something. And that's a really specific thing that then translates to great. And so I don't think you need to, like, you're right, you don't need to go everywhere, but I do think that a little bit could make your argument go a lot further.
Okay.
And it looks like we had a quick comment from Kevin in the chat, and then after that, Aitan, Brian, and then Shannon. And I put myself on the queue too. So Kevin asked the classic, what's the one thing you would do if you could change? Maybe you want to expand on that, Kevin, a little bit? Are you asking if there's one kind of magic bullet here, or if there's one, there's no such thing as panaceas, as we constantly go back to, but maybe is there one particularly useful policy impact or tweak? Is that what you're suggesting, Kevin?
Well, let me give you a little bit of context as to why I'm asking the question. I happen to be selected to be on a panel, a citizens panel, to review the ACT, which is Canberra's in Australia's health system. So I'm not quite sure why I was the one elderly male of the 30 panelists to be selected, but it's been a very interesting experience on being on this panel. And we have to be making suggestions as to what we would do, and it's really difficult. So I've been going around every time I happen to need to go to a doctor or a medical place. I ask them, what is it that you would do if you could change the system? What's the thing that you think is the most important thing we should do today? Now, this is particularly relevant for Canberra because we have, I don't know how many different nationalities here, but 50% of the people are from, were born overseas or had a parent born overseas. So we're a really diverse community. And so your study is particularly important to us. So that's my question that I've been asking every medical person that I can find what it is.
Thank you, Kevin, for your question. That's a great question. It's also a little bit tough. For me, when I think about one thing that I can change, it's less, I think a little bit more broadly and less of, let's just change this law and everything will be perfect. I think ideally, the thing that I would like to change is having equitable care for patients. When you show up to the doctor knowing that you're going to be treated justly and fairly, that you're going to have access to the resources and the treatment and the things that you need. Unfortunately, to get to that point, there's a series of changes that we need to make. But if I could sort of skip over that whole process and just say, this is the thing I want to change, that would be where I would pinpoint, is having this equitable care for all patients.
The guiding star. And really helpful context, Kevin, and that opens up another whole field of research for you, of comparative analyses here, Phoebe, that you could do. And because I think there are some policy impacts that could be teased out for a variety of different stakeholders, including overseas. Thank you, Kevin. And then, so it looks like I have Aitan next, and then going back to Brian and Shannon after that. So yes, please.
So my question is about the use of AI. As I understand, when they did some experiments, when they were like feeding AI with a lot of past data, the AI made pretty good predictions. And I wonder if it might be good as verification. I mean, not replacing the human doctor or whatever, but the doctor does the diagnosis but also running the AI. And then if the AI says the same thing, then you're maybe good. And if it says another thing, you need to reevaluate.
Thank you for that question and putting forth that point. I think potentially there could be space for something like that. So in medicine, and I talk about this a little bit in my paper, you do need the human decision making, but you also need it to go alongside the technology. So for instance, if a doctor is inputting medication for the patient, maybe they put something in and it has an ingredient the patient is allergic to. Then the symptom will prompt them and say, are you sure this patient is allergic to XYZ, right? So you have the doctor making that decision, but also working with the technology to make sure you're making appropriate decisions and ones that are safe for the patient. There could potentially be a space for AI. That's not a field, but I know it's a space that's growing. The one thing I would caution with AI though is while you have this technology and it's supposed to be neutral and it's supposed to have no biases, the individuals who made that AI, they do have biases. And so sometimes some of those things get filtered through into ways that the AI doesn't necessarily react the way that we expect or necessarily as neutrally as we would hope. So again, growing space, there could be opportunities for that to work here, but also caution in how might biases that people hold filter into that system that they're creating.
And there's even adversarial machine learning, where there could be purposeful efforts to manipulate these systems and unfortunately target individuals or communities. David Crandall runs the AI Center here at IU. It's a brand new thing. He's recently taken that on this term, and he's really interested in healthcare applications. So if you'd like to make a connection, if you do want to do yet another follow-on paper, let me know. For now, though, I think Shannon. No, Brian, you're next, then Shannon.
Good, interesting stuff. First, just I'll make the comment linkage that the emphasis on fallibility certainly fits with the Ostrom's work in terms of their concern about fallible people and how you develop institutions that work with fallible people. I'd be interested if you could say more about the patient-centered approach and particularly how to do this in this world we're much more aware of since COVID came along, where people are, to put it kind of constructively, much more willing to do their own research and much more skeptical or, of not ready to just trust experts and go along, and much more inclined to look out for themselves and make their own choices about, who they want to listen to and how the kind of patient-centered approach works in that world. So thank you.
Sure, and thank you for that question, Brian. I appreciate you bringing up that now patients more than ever have access to more resources than they did in the past, and now maybe have more impetus to make use of these resources, maybe instead of going to their doctor or other experts. So in this paper, when I was talking about a patient-centered approach, this is something I'll need to clarify. So more of my idea was thinking about when an error occurs, how can we make the patient a part of that process? So I mentioned this previously, how there's been a history of deny and defend, hospitals stonewalling, and refusing to give out any kind of information. So my idea with the patient-centered approach is, this error occurred. So how can we bring patients into this process to help address the harm that has happened, and how can we? So another point I'll make, and this is separate from this paper, but another piece I wrote talked about in addressing medical error. There have been some institutions, notably the University of Michigan, that have adapted a series of steps that they take in the aftermath of an error. So for University of Michigan, they call it, I believe, the 8 pillars. And so those are the 8 steps they walk through after an error occurs. And part of that process is notifying patients and their families what has happened, what has gone wrong, but also involving them in the process of what happens next. And there have been some cases in the aftermath of medical error where patients and their families, they've been harmed, and the hospital has said, we want to do something about this, and they've invited those patients to serve on some kind of board to help in the decision making, and sort of that process as they move forward with how can we prevent this from happening again. So that's the angle I was coming from when thinking about patient-centered, but I think you raised an important point, which is what happens before an error, or what happens before the patient even gets to the hospital, right? How can we keep the communication open between healthcare institutions and patients, especially after a time where a lot of patients might have a lot of skepticism or feel they can get the information themselves?
Excellent. Thanks a lot, Brian. And Shannon.
First of all, I love the way you're approaching the solution to this from more of a systemic way than the other way. I think that's really amazing. I also think you probably have a full book here with the kind of content you have. So 2 main things. So you're kind of talking about this adversarial versus collaborative approach in medicine. Which is this interesting idea that trust runs 2 ways. And for some reason between healthcare providers and patients, that trust is seemingly eroded over time. So I'm wondering if when talking about misdiagnosis, there's a way to kind of think about that erosion of trust and how that's played into it over time. Because I imagine if you're not getting the information provided as a doctor, if your patient doesn't trust you in that regard, that would probably lead to more misdiagnoses and create train. I'm also wondering if you note that there's obviously pretty well documented disparities in both sex. I think you mainly talk about sex and sexuality in this. I'm wondering if you have thought about differences in highly gendered areas or highly sex-based areas to more broad generalized medicine. And then the last comment I have is if you've considered age as one of these factors, just because I know my friends that study aging policy, there's a decent chunk of not believing old people when they say they're in pain. And then I swear that actually this is my last comment. The health policy workshop at O'Neill, I don't know if you've heard of it, but I'm sure they would love to have you speak there as well. They're mainly from an econ perspective, but they're generally really, really helpful and nice. So
We can connect it after this.
Okay.
That's great.
Yeah. Most of the comments, so I don't even need a response necessarily, but so I appreciate your first point about thinking the way you framed trust and the relationship that exists in medicine, one that can be adversarial versus collaborative. So the concept of trust. So I didn't do a lot of that in this paper. I've done some in my previous work and likely will sort of circle back to this, but you are absolutely right. Having trust, you know, with your physician or in healthcare is incredibly important for so many reasons, right? Whether you will tell them certain things, whether you're more likely to, you know, follow the treatment or take your medications, there's a lot. There's significant research in this area. There's some about what's known as doctor-patient concordance. And if like the doctor has the same race as the patient, how that can make a significant difference, especially when we're talking about racial and ethnic minorities, just having often that cultural understanding or awareness. And also your comments brought up this paper that I read recently, and I want to dig more into this space about the idea of having a patient diagnosis. So not just telling the patient, this is what's best for you, this is what you need to do, but listening to them and hearing their story and trying to come to this sort of resolution of what's the best diagnosis for my patient based on what I know about them and based on what they've told me. And that might not necessarily be, you know, textbook do X, maybe this person needs Y. So trust is incredibly important, but something I will probably save for another paper because it's so, I'm really trying, I think I cover a lot and I'm trying to streamline, but there are so many things that overlap. And then your question about sort of highly gendered areas in medicine versus sort of more broad things. That's not something I thought heavily about. So kind of in writing this paper, I'll go to the literature and say, and just look, where are we constantly seeing, these differences, whether it's along race, whether it's, along sex, gender, and kind of start to dig in more there. But, there's a lot of research on, Black women and mortality in childbirth. And so there are these different ways I've come across information in more gendered areas, but I haven't really explored that and thought to compare it with sort of the broader areas of medicine. But I think that's an interesting point, and that could add another angle. And then
To add to your paper, not streamline it.
all that. And then your point about considering age. So just thinking about different demographics or, what we call like social determinants of health, thinking about socioeconomic status, educational attainment. So these are all things that I often come across in research. And I'm hoping moving forward to start narrowing and targeting. So here I'm talking about 3 vulnerable communities. Like one good move moving forward could be, I'm going to focus on women in this paper, and that will allow me to dig into some of these finer points that you're raising. So I appreciate that. And the tip about the health policy workshop.
Yeah, we'd love to have you there. A great crew.
Yeah. Oh, yeah, great.
Very interesting. And the paper it's sprawling in some ways. I mean, I don't know how you're going to publish it yet. I haven't figured it. So a couple of, a model you might want to look at, even though could create a dilemma, is IU Health. It keeps getting bigger and bigger and bigger and bigger. And this is my 2 weeks of health checkups on all the different things I could go to. And the complexity of, they feed me through my IU Health portal and everything, so much information. It's overwhelming. I mean, it's like, so IU Health might be a good place as a case study.
What not to do.
Yeah, it's almost like if you started it with I'm thinking of a master's level case class. where you look at how you help it from your perspective. That might really be interesting. You know what? And two other points then. Lynn Ostrom always said, listen. When Lynn sat down with a group of people in a community about some issue, she always, and she had to sometimes put her hand on a graduate student and say, don't say anything, just listen. So your listening is really important. Now I'm going to give you just a quick story. I work in urban forestry, and I work with urban forestry nonprofits who work in areas to plant trees, and they think that they've got great programs to reach the communities of most concern. And when we've analyzed several of these nonprofits in the last few years, the mistakes they make that are so simple. For instance, the one nonprofit we work with, they have an application process where if a community wants trees, a neighborhood, you apply. You have to apply online. Well, that's a challenge right there. You have to have at least 2 leaders on your application, not one. And many of these communities are highly rental, and finding a second leader is really critical. And then one of their tree planters told me the story that he was in a neighborhood where they actually were planting trees, and he's planting trees in front of a house, and a gentleman is sitting on the porch drinking a cup of coffee. He asked him, he says, so what do you think about us planting this tree here? And the gentleman said, I'd rather you put in a lamppost. It was the disconnect of, there wasn't, it's not a safe neighborhood. They needed lighting. And yet we're worried about trees. And that may, those are the kind of things that you're thinking about. You might want to just simplify it into some really interesting, simple questions. But nicely done. And I agree with Scott, really nice, well-organized presentation.
Thank you.
And piggybacking off of that, then we're going to turn to Alfonso and Simon. I think there's multiple ways you could potentially break this up. I'm just looking at the word count, Phoebe, and these days, and for the audience, generally 15 to 20,000 words is a law review article, which is crazy, right? And half of it's footnotes, good Lord. But you're almost there, right? So I mean, you could break it up into like a medical error piece and a diagnostic error piece, do the case study, maybe the Bernie mentioned of IU Health, and then tease out the policy implications a little bit more. Like I like the high risk organization piece, which right now is just a couple of paragraphs. You could build that out because you note those critical infrastructure sectors and how they sometimes do this type of checking better. But you could tease out why, right? Maybe some of the information sharing that gets done in those sectors. And we actually run one of them here at IU for all of higher ed. So you could even talk to Kim Milford, who runs that. I could get you in touch, and that could maybe tease out some interesting other potential implications. So we can talk more about it, but that could be one way you can get multiple papers out of this, in addition to your AI paper and your trust paper and everything else. So anyway, just we can talk more about it. Okay. Just in the interest of time, Alfonso, please, and then we'll turn to Simon.
Thank you very much. The work there is very interesting. Years ago, I was more concerned about the errors being committed by juries in our judicial system, and Vince and I talked about that quite a bit. But you answered one of my questions, though. You answered my question about the determinants of health. I think you looked at that body of literature, or you're looking at it. But I was also wondering, though, in cases where you cannot make a diagnosis, that is to say, the current knowledge of the field will not allow a physician to determine exactly what is wrong with the patient. And particularly what we find is that we need to have post-mortem examinations, such as autopsies, to find out what's wrong with the patient. Have you looked at this literature at all in terms of autopsies, what you might contribute to your research?
Sure. So I haven't looked heavily at instances when, physicians they cannot make a diagnosis. One thing I did see in the literature that was interesting, especially when you're looking at, vulnerable communities or populations with lower socioeconomic status, is often the healthcare institutions they would go to didn't have the same resources or access to certain treatments. And so there would be cases where there were solutions that existed, but simply because of where they were and the institutions that they went to, they did not have access to those same treatments. And so for me, that was kind of an interesting, just an interesting idea that sometimes doctors are not able to make the diagnosis simply because they don't have the technology available. But I think to your point, more research into looking at what happens if the technology or resources don't exist. And I think that's a fair point because, technology and medicine and health, these are things that are growing each and every day, but it can't encompass or cover everything. So there will still be points where what we know and the technology we have falls short.
Yes. Thank you.
Thanks, Alfonso. Simon, please.
Yes, so I've been I really enjoyed reading the article. I think partly because as an Asian, I remember going to the hospital, and the doctor was very impatient because of language, and she used a lot of technical term and and I couldn't understand. I asked her to repeat, and she just became very impatient. She told me to get my phone out and just search by myself. So, and that really reduced kind of my confidence within the doctor to really understand my issue. And eventually I had to fly back to Taiwan because I couldn't get enough support. So my first question, and when it comes to race, are there any further studies on kind of language as a reason to cause this diagnostic this error, and also maybe any studies on Asian patients? And the second point is, I come from the law school, so I was wondering whether you're planning to elaborate this or to intersect this with critical race theory as a way to, especially on the race part. And also, are there any tension that you see when it comes to race as a factor with race scientists? Let's say if I drink a little bit and I have the Asian flush, are there anything that do you see like a tension there? Like it actually proves that maybe some race are more easy to have some kind of health issue. And speaking from not a medical background here, just a question on like the tension between your research and race scientists, and also your research and critical race theory. Thank you.
Simon, I appreciate you starting by sharing about your own experience. I can't imagine how that made you feel. And I'm sorry that person treated you that way. And I wish I could say that your story is unique or stories like that, but unfortunately, that sometimes happens in medicine, and not just medicine, other fields. So you started with this idea about doctor-patient communication and these ideas of language barriers. So to your first question, there is tons of research about language and the barriers that exist there in terms of care. That has not been a focal point for my research specifically, but I've come across a lot of this literature in the work that I do. To your point about critical race theory, interesting point. When I was writing my first paper about medical error, someone also raised critical race theory to me as a potential avenue or connection or a way to frame my work. I don't identify as a critical race theorist, but I think as my research starts asking more of these questions, it's giving me more grounds to expand into this space and to start looking at where might be some of the overlap or the ways that my research intersects. So I appreciate you also raising that point. And I just want to make sure I have your last question clear. It seems as though you were asking, and correct me if I'm wrong, do I see in the literature if some racial groups are more likely to experience certain groups than others? And so the answer to that is yes. There are certain things among populations that just seem to be more common across racial groups. But the interesting question is is it because of their racial background or other social and cultural aspects that might lead to this? So for instance, taking the African-American community, community. Often this group tends to be predisposed to higher rates of diabetes or higher rates of hypertension. And so then one question to ask is it simply because these individuals are a part of, the African-American community that we see XYZ? And sometimes there are genetic factors, but is it a cultural thing? Is it a social thing? Because often when you look at this community, you see a lot of African Americans that live in lower socioeconomic areas, or they might have less access to healthy foods, or, their areas or neighborhoods might not be as safe. So you can't, be outside walking or having your children playing. And so short answer is yes, you can see some races more likely to have certain medical or health issues, but there's often sort of social lens that you have to look at. It's usually a combination of genetics and also society that leads to these discrepancies that we see.
All right, thank you so much.
Those are great question. An important comment, Simon. Unfortunately, we are out of time, Phoebe, but I don't know if you had any final, thoughts or reflections before we have to close.
Well, I just, again, want to thank everyone for being here and, raising these questions, some of which may make it into my paper, some of which might be on the growing list of future papers. But no, I really appreciate this. It gives me a chance to talk about my work, but also consider areas or holes that I might have missed or overlooked. So thank you again.
Very well done, Phoebe.